Good evening, everyone. My name is Tanya Kidd, and I'm the program manager here at Team Phenomenal Hope. I would like to thank each of you for joining us this evening for our pH Awareness Month webinar. This is our second webinar series. If you missed our Informed Patient Tell-All webinar last month, please scan the QR code on your screen, and that webinar will be shown. You can look at the recording of that webinar. And for you, those of you who are new to Team Phenomenal Hope, we are a nonprofit organization founded in 2012 to raise awareness on pulmonary hypertension. Our mission is to provide patient-centered programs and educational resources to those living with PH to improve their lives, bring them out of isolation, and contribute research dollars to locate better treatments and a cure. Of course, this would not be possible without our sponsors, our wonderful sponsors. We would like to thank Johnson & Johnson, CVS, Carol's, and Bayer. First, a few announcements. To check out our programs, all of our programs here at Team Phenomenal Hope, including our next support group meeting, please scan the QR code that you see now on your screen. Those are our programs listed there. One program I would like to highlight in particular is our new Phenomenal Connections peer-to-peer pilot program. It's a free program that connects trained volunteer peer supporters living with PH with other PH patients who need support after receiving a diagnosis. For information, please visit teamph/phconnect.org or scan a QR code on your screen. We also invite you to join us for our final PH Awareness Month webinar, the virtual town hall, on Wednesday, November 20th at 7 p.m. Eastern Time. Please scan a QR code to register or visit teamph.org. Also visit our PH educational resource website, learnlivebreathe.org, to learn more about the latest research, medications, treatments, and how to navigate and manage PH. This is a phenomenal resource for patients and caregivers. So we will have a Q&A at the end of this presentation. You can use the QA button at the bottom of your screen to input any of your questions. A box will pop up. You can type your questions there, and we'll get to those at the end of the presentation. Also, before logging off of this webinar, there will be a pop-up survey. It would be greatly appreciated if you can complete this survey to share your thoughts and feedback on today's webinar. Today's webinar will be presented by Dr. Sarah Medrek on the critical topic, social determinants of health and pulmonary hypertension care, pointing to socioeconomic factors such as access to specialty care, income, social support, and education as the fundamental causes of the wide range of health outcomes among those living with the disease. Dr. Medrek is an associate professor in the Division of Pulmonary Critical Care and Sleep Medicine at the University of Mexico Health Sciences Center. She is dedicated to improving the health of all patients with pulmonary hypertension. So without further ado, here is Dr. Sarah Medrek.
Thank you so much for inviting me today to give this talk. As Tanya mentioned, my name is Sarah Medrek, and I work here in Albuquerque, New Mexico, both at the UNM Health Science Center, at our PH Center there, and also at the VA hospital. And I did have the opportunity to attend last month's webinar as well, which was on exploring cultural perspectives in pulmonary hypertension. And so I think that this topic, which is social determinants of health and pulmonary hypertension, really dovetails nicely with that topic. And so I did try to incorporate some of the perspectives that were expressed during that session, but we all also will welcome feedback at the end of the session. There's the Q&A option as mentioned. So we will have time to discuss any questions or comments or feedback you may have. So I'll go ahead and get started. And I did want to get started by presenting a patient case. However, I didn't really want to include patient details. So I will introduce you here to Miss AI. She is not a real patient. She is, of course, generated by artificial intelligence, but I did use a lot of the features and clinical aspects that we do see in taking care of our pulmonary hypertension patients. So I hope that a lot of the things that you see in her do resonate with some of the patients that you may see or that you may have experienced in your own experience as a patient. So this is Miss AI, as I mentioned, and she is a 47-year-old unhoused woman with ongoing methamphetamine use who goes to the emergency room with progressive shortness of breath. And she's going to the emergency room really as kind of a safety net option, as she doesn't have health insurance and she doesn't have a primary care provider. So while she's there for her progressive shortness of breath, she does have an evaluation, and her laboratory studies do show a significant elevation in the NT-proBNP level. And a CT thorax with contrast is done, and this does not show pulmonary embolism, but shows significant pulmonary artery enlargement. So the ER provider is concerned, very wisely, that she may have methamphetamine-associated pulmonary arterial hypertension. And they recommend in the discharge instructions that she follow up with her primary care physician. So where does that leave us? In my impression, this leaves us with a really long road ahead. It's a really long road to get Miss AI on the path from diagnosis to treatment. And I have a lot of logistical questions, like how can she even make it to that end goal of getting on directed therapy for PAH? These are some of the questions that I have, although I'm sure you could think of other questions as well. So say she doesn't have great literacy, say she has difficulties with reading, especially complex medical knowledge. How will she even read the discharge instructions to know that they have this concern for this very long thing, which is methamphetamine-associated pulmonary arterial hypertension? And how does she know that she needs to follow up with a primary care physician? And say she doesn't even have a primary care physician, how will she ever make it to see a pulmonary hypertension specialist? And what if she lives in an area of the world or area of the country where there isn't a pulmonary hypertension specialist? If she doesn't have good resources, how does she pay for testing and appointments? And if she doesn't have transportation, how can she make it to all of the appointments that she's going to need to go, both to get evaluated and diagnosed and to get follow-up? Say she still is using methamphetamines, how can she access substance use counseling? Having her stop substance use is something that would definitely affect the course of her disease. And so that's something that's very critical and key. And let's say she does get on PAH therapy and she doesn't have a stable housing environment. How can she store and take this medication home if she doesn't have that stable home environment? So as I said, these were some of the questions I had about how she's actually going to get on directed therapy for PAH. And like I said, I'm sure you could brainstorm other ones, but all of these things are the social determinants of health. So to kind of point into the direction of what the social determinants of health are, healthypeople.gov defines them and categorizes them into 5 different categories. And so you see these are the social determinants of health, and sometimes that is abbreviated SDOH. And so you'll see that there's 5 different categories, and we'll go through these 5 categories briefly. And then after we go through them, I will try to relate them more to PH specific topics. So the first one that is on the list is economic stability, and this includes things like employment, like food insecurity, housing instability, and poverty. The next category is education access. This is something really that starts in childhood but progresses throughout your life. It's hard to be able to participate in your care if you have lower levels of language and literacy, for example. The next is a really, really big one for PAH, and that's healthcare access and quality. So you need not only access to that subspecialized care, which is PAH care, but you also need access to primary care. And so these are really important things to consider and things that we'll talk more about. The next category, this is number 4 for those 5 categories, is the neighborhood and the built environment. And so this includes things like access to food, whether or not there's crime or violence in the neighborhood, the environmental conditions, and the quality of housing. And finally is social and community context. And this varies a lot. by community, whether there's civil participation, whether there's discrimination in the community, whether there are many community members that are affected by incarceration, and then social cohesion, how strong those social networks are. So one question I had when I was preparing materials for this talk is, how does race and ethnicity fit in? And you'll see I didn't mention race or ethnicity in the social determinants of health. And really, the way that this fits into the puzzle is that health disparities adversely affect groups of people who have experienced greater obstacles to health based on their racial or ethnic group. And so, kind of written in another way, or kind of just depicted in a different way, we have our social determinants of health that I went through, these 5 categories from healthypeople.gov. These social determinants of health affect marginalized groups disproportionately, and that would include people who have been discriminated against due to their racial or ethnic background. And these differences in social determinants of health lead to the health disparities that we see and the differences in health outcomes that we experience in the realm of PAH. So I wanted to start introducing some PH-specific topics into the social determinants of health. And this diagram, I think, is a little bit complex, but I think it's kind of complex for a purpose because it just shows how complex and interrelated and kind of what a tangled web this is. But this is a diagram that was published in 2017 from one of our pulmonary journals. It was kind of a statement about health disparities in patients with pulmonary arterial hypertension, a blueprint for action. And this was the relationship that they proposed between socioeconomic status and healthcare access in the setting of pulmonary arterial hypertension. And so you can see that there's a lot of things that play a role here. You can see that health insurance status is related to the socioeconomic status. And depending on your health insurance status, you may or may not have poor healthcare access. Whether you live in areas where you have availability of these advanced diagnostic modalities or these abilities to advance lung disease also kind of plays into this role in this column of poor healthcare access. Also, all of these things are interrelated, and indeed it is kind of a tangled web. There's a lot of interplay between all of these things. And I think that this is really enhanced, like this complexity of the relationship between social determinants of health and healthcare access is just really amplified in pulmonary arterial hypertension because it is such a complex disease. And I just included a couple of diagrams from our 2022 ESC ERS guidelines that just kind of highlight the complexity of how difficult pulmonary arterial hypertension is. So we have a disease, yes, that has one name, but has 5 groups. And in all of these 5 groups, there's multiple subcategories. We have a disease that requires all of these steps, all of these diagnostic techniques in order to appropriately categorize which one of those groups you fall into. And these complexities don't even account for the complexity of treatment regimens after you've actually been diagnosed with pulmonary arterial hypertension. So I think this is a disease state that lots of physicians don't even really understand. So the complexity of this disease state, I think, really amplifies these disparities in care and makes it that much more difficult for our patients to get the care that they need. So how do the social determinants of health affect PH care? And to kind of start this conversation, I looked at this paper, which was published in 2022, and it was regarding the social determinants of health and pulmonary arterial hypertension. And so during this survey, what they did is that they conducted semi-structured virtual interviews with US clinicians at 17 pulmonary hypertension centers. And I would say, I kind of wish that they had included more patient advocates or patient representation. I would say that that's one limitation of this study is that they did primarily have clinicians do this survey and not necessarily patients. But I think that a lot of the things that they pointed out as part of this survey are really relevant, and I'm going to point out some of those things. So the way that I structured this is using those same 5 categories that we had from healthypeople.gov, and then just including kind of illustrations and examples that are relevant to pulmonary arterial hypertension. So Employment is really a big one. You may be unable to work due to your medical illness, either because you're not able to do the physical tasks or you're too conflicted in your time because you need to attend appointments. But lack of employment is difficult for a number of different reasons. And I mean, first is economic status. Employment is how you earn money. Lots of cases, employment is also how you have health insurance. Unemployment is also important for personal fulfillment. From the session last month, there was a patient with PAH who mentioned that they were diagnosed with PAH during college, and that just kind of completely derailed their life journey. And that's so important, and we need to keep that in mind. Other aspects of economic stability include housing instability. Our treatments often are complex and require electricity, for example, to operate oxygen concentrators and medical infusion pumps. And sometimes this is not able, for example, if you live in an urban environment and you're unhoused, but also New Mexico is a rural state. And so we have a lot of patients who live off the grid or live in their RV and don't really even have a stable source of running water or a stable source of electricity. So I think all of these factors are important to consider. It's also important to have a clean environment if you're on an advanced therapy, such as IV or subcutaneous therapy. And then poverty, very linked to employment in a lot of ways. But if you don't have money, how do you pay for medications? How do you attend visits? The next topic, number 2 here out of our categories for social determinants was education, access, and quality. And so this paper, rightly pointed out that pH medications have complex treatment regimens. Sometimes they have automated pumps, and so you need to know how to work the pump and how to troubleshoot the pump and how to do titrations of medications. It's a complex disease. Like I said, lots of physicians don't even understand pH. And, patients do either have to have some knowledge of the disease state or else have a lot of social support in order to be able to comply with these complex treatment regimens. And then, as I said, healthcare access and quality is a huge, huge one. And so we'll talk specifically about pH and just the fact that we don't possibly have as many pH centers as would be needed to serve all of the population of America. But I would say that also access to primary care is important. As it turns out, our patients have more than just PAH. It's not just pulmonary hypertension that they have. They have lots of comorbidities. They need to be treated in a multidisciplinary fashion. They need to have access to mental health resources and access to substance abuse counseling. And as I mentioned, we just don't have coverage in regards to having enough PH clinics, I would say, throughout the United States. So this is a map from the PHA, and it shows the accredited centers of comprehensive care as well as the accredited regional centers. And you see a whole lot of dots or markers kind of along the East Coast and some along the West Coast. But then, you see big parts of the country where there's not even really any centers. I mean, even Nevada has a lot of people in it and there's no PH centers. And then, God forbid you live in like North Dakota, like you can't even drive to a PH center. I mean, I think that not that other people can't treat pulmonary hypertension, but there's just so much data out there saying that being treated in a PHA accredited center by providers that are knowledgeable about pulmonary hypertension does improve outcomes. Another aspect of PH care is whether you live in an urban environment or you live in a rural environment. And this is kind of a dense graph, and so I'll talk it through a little bit. But I was just going to start by saying where this data is coming from and what they did in this study. And this study was published in 2020, and it talked about urban-rural disparities in pulmonary hypertension mortality. And it looked at a commercial health insurance Medicare Advantage database. And it took all of those patients, identified the patients that had pulmonary hypertension, and followed them up for a time period. That's what's on this x-axis here. And then they looked at mortality or survival and plotted those two things against each other. This analysis was actually adjusted for things that make people die sooner, such as advanced age or increased disease severity. So then they kind of plotted out survival based on the region or type of care or area in which you live. So you see at the top, you want to be at the top because that's 100% chance of survival. You don't want to be at the bottom where it's 0%. So the top people are doing better. So you can see metropolitan here and urban there, and then rural is kind of all the way down there. And this is something, living in New Mexico that's very near and dear to my heart since we live in a very rural state. And it just points out, even after you take into account the fact that people are different ages and have different disease severities, the people who live in the rural setting are still surviving not as well as the patients who live in more urban centers. Excuse me. And then this is another aspect of care, which I think is important. And I'm not really trying to be political in this statement, but I think it's something important to consider. This was a statement that was published in 2023 in one of our journals. And it was about access to medically necessary reproductive care. And so, as we know, having pulmonary hypertension and being pregnant is a very risky proposition. And so in some cases, termination of pregnancy is considered a valid treatment option for patients with pulmonary hypertension who become pregnant. And so this map of the United States highlights the PHA accredited centers. It was that same map that we saw before, but now has overlaid on that whether or not states have a protective policy regarding termination of pregnancy or a restrictive policy. And now you see that there's just vast swaths of the United States that are care deserts where patients may not have access to the care that they desire. So moving on a little bit from access to care to neighborhood and environment. One of the things that was highlighted is whether or not that people have access to foods that support healthy dietary patterns. And in this survey, they did mention that in some cases it is difficult for people to eat healthy meals and to follow sodium and fluid restrictions. And one of the examples that was provided within this paper was, say you are unhoused and you do eat your meals at a soup kitchen. That is not the ideal place to get food. Soup is, typically very high in sodium, high in fluid. But, if that's what you have, that's what you eat. And then I thought another important point from last session that really kind of struck me, because it wasn't something I'd really thought about before, was whether or not the recommendations we have regarding following these sodium fluid restriction are culturally sensitive. Like, yeah, we can tell somebody to eat like chicken breast and broccoli, but if that isn't part of their cultural tradition, that's not something they're going to adapt. It'd be better if we're able to provide recommendations that would fit within their culturally appropriate food. Other things about neighbor and environment, if there's crime and violence in your neighborhood, that definitely causes stress, which is not good for pulmonary hypertension. And then air quality is also something that affects breathing. And this was a point that was made in the publication from the 7th World Symposium on Pulmonary Hypertension, and just is kind of a comment about changing global climates, and does note that patients with cardiovascular diseases are at a 4 to 7 times greater risk of mortality during extreme heat events. Heat events or having a high temperature can increase the heart rate. It can increase sweating, which may decrease the total body volume, which could mean that diuretics would need to be adjusted. And then specific to PAH, they do mention that patients on intravenous prostacyclins or implanted pumps should be aware of faster flow rates during extreme heat. So I think this, is definitely a topic that's hard to fathom and difficult to think about, but I think it's reality, unfortunately. Next is the social and community context, and we'll talk about a few different aspects within this, both how racial and ethnic differences may result in discrimination, and talk about language barriers and culture barriers. And this is something very relevant to us in New Mexico, where we are a majority minority state and have large Hispanic populations, Native American populations. Especially like our Native American patients, they have so many barriers that they have to get through. First, language, if they don't speak the language, that's definitely a barrier. Cultural barriers, especially regarding death and dying, have a very different opinion and different context within that culture as we do in kind of traditional Caucasian culture. And then a lot of our Native American patients live on reservations, and they may not have access to like all the housing things that we would ideally like, including running water. And then also in the realm of discrimination, there has been a notable lack of clinical trial and registry enrollment among racial or ethnic minorities. And so this is from a paper that we published in 2018 that just really pointed out the fact that there has been poor clinical trial enrollment among minorities. You can see kind of going back to some of these historic studies. This was a historic, from 1992 about calcium channel blockers. They didn't even report race or ethnicity. The same about kind of the landmark study looking at prostacyclins. You can see looking at percentage white, 85%, 78%, 85%. And as was mentioned during the last session, a lot of this really is based on a lack of trust, which I think is very, very validated based on historical abuses. But that doesn't mean we shouldn't try to change it. Like, this is something we need to change. We need to increase our enrollment of minorities. We need to gain back their trust, because they're not going to get the care that they need that's directed, that works for them with their unique genetic and cultural makeup. This is similar data kind of published in a different format. This was from a paper that was published in 2023, showing race and ethnicity in PH registries. This is the REVEAL registry, which was a US-based registry. You can see a little bit over 70% white. This is the US Pulmonary Hypertension Scientific Registry, which is almost 90% white. That's not really reflective of what our overall population is. And then the FAR, honestly, kind of similar to REVEAL overall in its demographics and race ethnicity makeup. And then I kind of highlighted some of the older studies, but I want to just point out one of our newer studies, Pulsar, which is looking at sotatercept, another landmark trial. I was really blown away by this. Over 90% white. I don't even see a bar for Hispanic patients. This is something that we need to do better. So discrimination is not only due to racial or ethnic background, but also due to other things. Weight is one. Patients that are overweight are often discriminated against. Economic status, health service, health insurance status, LGBTQ status, and gender. And then finally, just highlighting the importance of social cohesion. It's so important to have social support when you're managing a complex disease such as PAH. So kind of to summarize, yes, social determinants of health are very important in PAH. And I guess the next question, how does this affect outcomes? And to me, it just seems really intuitive that, yes, of course, this affects outcomes. But I do think it's good to kind of prove your point and do the work and show some of the data. And so I have one study that I was going to highlight for that purpose. And this was published in 2022, and it looks at data from the FAR, which is the Pulmonary Hypertension Association Registry, which is the largest active longitudinal registry in the United States. It was began in 2015 and includes over 40 pulmonary hypertension care centers and over 1,200 patients. And the point of this study is that they created a model called the FAIR to determine whether information pertaining to social determinants of health can predict a composite patient outcome. And that composite outcome was death, all-cause hospitalization, or clinical worsening. So this is some of the data that they're able to extract from the database. So they did have information about race, insurance, marital status, and then some basic demographics and information, but really not a whole lot of nuanced data. You could definitely obtain a lot more complex information from people. But regardless, they looked at these factors, and these were some of the variables that correlated with an increased risk of having an event, although in many cases they did not reach strict statistical significance. And these, I think, include the things you might predict, including Black race, public insurance, lower level of education, lower household income, higher number of people in the household, higher BMI, prior drug use, or male gender. So then they put all of these social determinants that they extracted from the database and then looked to see if this information on its own would predict outcomes. And they excluded other relevant things such as hemodynamic variables or functional status or age or any of those other things. And this model that they created actually did have ability to predict outcomes. And I won't go into all of the details of this other than it worked, this model that they built. And I think that is really important given that it excluded all of the other important things that we usually look at in risk stratification. So I think this proves the point pretty well. So then what can we do to make things better? And I think this is like a really huge question. And I just want to pause and acknowledge that it is a very complicated topic. And it's like, yeah, you could just fix society and we'll make it all better. I mean, these are like really big issues, but I think there are discrete things that we can do in order to improve our care. And so this paper that I talked about previously about social determinants of health recommends that you could include a social determinants of health screener when you're enrolling patients in your clinic. And so, it's relatively short form. It has pictures, asks about, whether you have a stable housing situation, whether or not you're concerned that there are bad exposures within your home environment, whether or not you have access to food, if you have concerns about access to utilities, whether or not there's access to transportation to get you to appointments, whether or not you've been worried about getting medications. If you need, lots of our patients are caretakers themselves, and that definitely affects their ability to take care of themselves. Whether or not there's issues with legal issues, if you feel like you're safe in your home or if you're having issues with other family members, and whether or not you feel safe. And what they recommend is an integrated model that includes a lot of different members present within the clinic and starts even with your receptionist or your medical assistant. You can have that medical assistant hand out the 10-item screener and have the patient fill it out while they're in the waiting room. You could also have information in the waiting room about social determinants of health or ways in which they could link with services they may need. If you have PH coordinators, you can have them review the social determinants of health screener and try to link them with resources in the community and also counsel patients, about what to expect with this disease process and the things that they should be planning ahead for. And then as PH clinicians, I think we have a really important role as well. One of the things that was mentioned during last session, which I think is kind of like the elephant in the room, is the cost of medications. I mean, honestly, it's hard for us as clinicians lots of times to know like what the take-home cost of a medication is, but I think we can at least have like a hierarchy of how much a medication may cost based on, talking to case management or other members within your clinic staff. Because although you might pick like the very, very best therapy for a patient that has the most data and the most evidence, if it's a medication they're not going to be able to afford, it's not going to be taken and it's not going to have any use. And in that case, you may have to target a medication that is something the patient actually would be able to obtain, even though it might not be like your number one choice. So I think it's important to keep these things in mind, although also acknowledging these are really hard topics. Other people within the clinic, administrators, trying to do what you can in order to create resources and making sure resources are available, transportation is available. And then social workers, they know the most about how to get people the services they need. And I think that's such an important aspect of a care team. Within our clinic in Albuquerque, we have social workers who help with a lot of these aspects, and then case managers who really advocate for patients and getting them the medications they need at an affordable price, and such an important aspect of our team. So other things that we can do, we can study this more, and that's something that our center has been involved with. We've been working with colleagues in order to submit this study, which has been submitted to PCORI, which is the Patient-Centered Outcomes Research Institute. And this study is called A Clinic Community Targeted Social Prescription to Help Pulmonary Hypertension Patients Reach Health Goals. And so what it's aiming to study is our population, which is adults with pulmonary hypertension. The intervention, so what we're going to do for those patients is this clinic community rare disease targeted social determinants of health program versus just usual care, what you would do for everybody else. And the outcome measure is health related quality of life. So these questionnaires that we have just to kind of gauge how well you're doing holistically. And then I will show the timing of this project in a subsequent slide. And this proposal has been submitted by members of the Latinx PHT Consortium, which is a self-funded consortium of poor pulmonary hypertension centers within the Southwest. Our centers are unique because we have a Hispanic enriched cohort of patients, and that has been a population that has been underrepresented in clinical trials and registries. And so for this project, what would happen if funded is that participants would be identified, and then they would be randomized either to usual care, which would be kind of typically what your clinic is doing, or they would be randomized to this clinic community intervention. There would be a little bit of crossover of this group, but the things that they're analyzing at different time points are these quality of life measures. So what is this clinic community intervention? In this integrated approach, community health workers and clinical social workers will work with patients to address social determinants of health-related barriers to care. And what would happen is that patients would fill out some of these surveys and their responses would be assessed in order to identify their needs and to identify their goals of therapy. And then based on this analysis, a social prescription will be provided to link patients up with community resources, and barriers to healthcare will be identified and addressed. And I think this project is really, really important, and we're really optimistic that it will get funded, because I think PAH is such a complicated disease, and we need to have more concrete strategies on how to address these social determinants of health. And I think this project is also important because these results could be translatable to other complex disease states. So I'm really hopeful that this does offer a path forward and we'll receive the funding so we can do this important work. So I'd say the practical things we can do now, though, I would say as providers, I think it's important to understand the complexity of this disease and its treatment and to acknowledge how social determinants affect delivery of treatment. I think as patients, it is important to advocate for yourself and share your own unique perspective and your own unique background. As clinics, I think it's important to consider integrating some of these questionnaires. I really like that 10-question social determinants of health questionnaire that I posted earlier in the slides, just as kind of a screener and to get an idea of like where you're coming from so we can best meet your needs. And then I would say as a community, provide support and resources to each other. And I would say I'm really appreciative for the role that Team Phenomenal Hope is doing in this, because I know that they're bringing the visibility to these important topics and are linking up patients and providers and other members of the pulmonary hypertension community. So thank you so much. I'm going to stop sharing and we can have some discussion.
Okay. Thank you, Dr. Medrek. Wonderful, wonderful presentation. Such critical topic, especially in the space of pulmonary hypertension. And, the question that you posed was, what can we do better? And I think we all can leave here today with something that we can do better, especially medical professionals in the different clinics and medical field. Understanding identifiers, self-advocacy, and as you say, surveys and questionnaires. So thank you for sharing this wonderful information, very informative. And we have a few questions here that I will read out. And the first question we have is, what is the difference between metropolitan and large urban? I thought they were the same. If you can speak on that.
Oh yeah, great question.
Yes.
I think that it is defined differently for the purposes of that study. And I don't have that exact information, but I'd imagine that metropolitan would be a little bit bigger than large urban. And so it's just based on population, really, and they classify patients based on the population of the city or town in which they live.
Okay, great. We also have one raised hand. Mr. Hicks?
Thank you very much. I just wanted to make a quick comment, if I may. Dr. Medrek, I've been a PH warrior since 1994, and I just want to say to you that your presentation was superb in every respect, well thought out and delivered in a manner that was easy for all of us to understand. And I just want to say thank you, thank you, thank you for this and everything else you do for our PH family. Thank you.
Well, thank you so much.
Thank you. Thank you for sharing that. Okay, the next question will be, you could say marginalized instead of minority, since numerically, minority may not actually be true. And marginalized can also capture a bit more of the context and relevance as well.
That's a great point. Thank you for bringing that up. That's absolutely true. I will take that into consideration in the future, especially like as I said, New Mexico is what we call like a minority majority state. Our minority population is actually larger than our non-minority population, which anyway, the logic is there, but I appreciate that feedback. That's important.
Yes, thanks for that. The next question is, obesity is a big problem. Why don't centers have nutritional counseling?
That's a great question. I think they should. I think nutrition is such an important aspect of PAH care, especially, these days now that we have some more therapeutic options, pharmaceutical options for treatment of obesity. I think that would be a great service to add to kind of like the multidisciplinary care that we know PH patients need.
Yes, and that is very critical when it comes to how food, diet, and nutrition affects health and wellness. So
Mhm.
the next question we have here is, have you had success enrolling minority populations in clinical trials?
I have, but I think it's hard. I think you really need to work on that relationship and really build that trust and kind of allay all of the fears that they may have, because there are real and important things that have happened historically to minorities in these settings or to marginalized populations in these settings.
Yes,
So I'd have, but I think that it does take work and it takes nurturing of that relationship.
yes, which is a part of, why we're having this discussion on those determinants of health. Thank you. Okay. And the next question is, what are your suggestions on how we better help individuals living in the area with no PH centers at all?
That's a great question. I think that I think there can be a role for telemedicine, in a lot of the situations. I know you don't get the full panel of care that you would necessarily if you're doing telemedicine, but I think that's an option. It just is hard for areas that are so rural that don't have the population to support a specialist. So, like I said, telemedicine I think could be an answer.
Yes. Okay. Thank you. Okay. Another question we have here is, what do you think would be better ways to capture our minority community in studies when it seems a lot of our studies tend to include our minority populations that struggle with more comorbidities?
Yeah, that's a great question, Natalie. Thank you for asking it. And I do wonder if that's affected, like, especially the pulsar. I was just, like I said, I was personally kind of blown away by the fact that over 90% were white. And I think that's probably a big part of it is a lot of people are excluded based on comorbidities. I don't
Yes.
know the answer. I guess, it's hard to say, like, well, we could change our recruitment criteria as part of the clinical trial design because then you might not get the answer that you're hoping to get.
Hmm.
I'm
Okay.
not sure if I have a great answer. The other aspect of this is, just studying more. You have the initial clinical trial. I think it's important to kind of not stop there with the initial clinical trial. I think it's important to integrate results from real world data in order to capture more of these complex patients and see how they do on treatment. So I'd say that's one path forward that I can think of.
Hmm. Okay, great answer there. Okay. Do doctors ever talk to pharma about their prices?
Do they? I would say yes. I think we're aware that medications cost a lot of money. I would say we don't have a lot of ability really to change that on a personal level, as a physician. I think that's why it's important to have groups like Team Phenomenal Hope to increase advocacy and awareness for, things like this, because we do have more strength as a group.
Yes, and we all know that pharmaceutical companies are the ones that set the prices, and organization like ours can help to navigate those resources to help, to afford those medications. So great. And why aren't there more PH centers in rural areas? Is there like that was kind of a question earlier,
Mhm.
better help individuals living in areas with no PH centers. So you kind of answered, you
Yeah,
know, the question.
absolutely. And you know, I think one of the things is just population density. I mean, although PH is far from rare, it's still not as prevalent as other disease states. So I think just, you know, lack of population density is one thing. I think the other thing is it's hard for to recruit physicians to rural areas. Just logistically, you know, there's not as many resources, and you know, people don't necessarily want to live in those areas. So I do think physician recruitment is also something that plays a role here.
Exactly, exactly. Okay. Let's see. Are there any other questions? Okay. We do have one hand raised, two hands. So we'll go with Lanice, you have a question? Let me make sure that you're able to. Okay. Okay, Lanice, you can speak. You can just unmute.
Okay.
There you go.
I would just like to say thank you to Doctor, because this was seriously a great webinar, because it does hit on a lot of issues that are not usually spoken about. When you talked about the rural areas, that is really an amazing thing, that in this day and age that people can't get to their PH centers, or can't get the medicine. And that is heartbreaking in a lot of ways. And you brought that to the front. So I thank you, Doctor, for doing that.
Thank you for participating. I appreciate it.
Yes. And thanks, Lanice.
Yeah, those are great questions. I mean, I think this can be addressed on, you know, a lot of different levels, just because medical training is so extensive and long. Um, I think, you know, supporting marginalized groups who are interested in PH is always a good way forward. So if that, you know, could include things like supporting their participation in a conference, I know that's always kind of a good pathway to get medical trainees interested in the topic, is to have them present something at a conference and have them participate and kind of get exposed to the bigger community at large. I think supporting things like their travel, their research initiatives, I think those would all be good strategies to help entice people and medical trainees from marginalized groups to pursue pulmonary arterial hypertension. I think collaboration, you know, if you are working at a medical center that doesn't have a PH center, I do think there's a lot of ways forward in terms of collaboration via telemedicine with a PH center. And I think that would be a great path forward given increasing technology in this day and age.
And I would like to add, you know, we're dealing with, you know, multiple barriers once again, and with pulmonary hypertension, the lack of knowledge about the disease and the condition, as well as, you know, including these social determinants of health there. So there are a lot of aspects to consider and to resolve.
So like one of the issues with a lot of these medications is that they're still new and on patent. You know, that's kind of like the drug company, the pharmaceutical company invests so much money to do the clinical trial and do the research and get the drug to market, that they do have that protected period of time during which the medication is on patent and can only be produced by that one pharmaceutical company. So I think that is a great strategy for medications that have come off patent. And I think that it has been successful in a lot of other areas. So I think that is a great path forward, but just wanted to kind of comment on that limitation.
Thank you. We do have one other comment here, said amazing conversation and topics. In addition to the questions about pharmaceutical companies setting prices, always important to express financial needs to specialty pharmacies to find all available resources in collaboration with the healthcare providers and manufacturers. Exactly.
Yeah, and I think that's why, at least in our clinic, we so appreciate our case managers and our social workers for really understanding all of these programs and understanding all of the opportunities to get patient assistance, just to make sure we're really able to support our patients and get them the medications that they need.
Great, great. Yes, great conversation and presentation today. And I would like everyone to make sure that they answer the survey. Well, I'll say complete the survey. It will pop up once you leave out, but there's also, if you're going to leave out before, there's also a link to a form that you can complete the survey. And once again, we appreciate your feedback and thoughts on today's webinar. And also remember we want to thank our sponsors again, Carol's Johnson & Johnson, CVS, and Bayer. And make sure that you all join us for our next webinar, which is our final webinar for the pH awareness month here. And what you're seeing on your screen now is our next support group. And then we have our town hall, once again, Wednesday, November the 20th at 7 p.m. You can scan a QR code or head over to teamph.org under our events, and you will see that. But we look forward to you joining us. Is the next webinar, which is the town hall. It's going to be a great discussion. We have many presenters, and we look forward to seeing you there. And that is all for tonight. We're a little ahead of time here, and thank everyone of you all for joining us tonight. We greatly appreciate your support and participation with Team pH, and we look forward to continuing to serve the community and education and so forth. Thank you all, and have a great night. Thanks, Dr. Medrek. Appreciate it.
Thank you.
Thank you all for
Okay.
your questions as well.